student of B. Sir, I am presenting the case of a 21-year-old female, a student of BCA, a resident of Uttam Nagar, New Delhi, who came with the complaint of swelling around eyes and bilateral lower limbs since the past 25 days. The history is provided by the patient herself and her mother. My patient was apparently asymptomatic 25 days ago when she developed swelling around both the eyes, which she first noticed. Actually, video start नहीं हो पा रहा है क्योंकि the host उसमें लिखा है कि
there is a lot of disturbance. I don't know.
Sir, I am not able to start the video. Hello, yes, sir.
Let me check for the video.
It's saying that the host has stopped it.
सर आप एक बारी दोबारा से ट्राई कीजिए.
ये अभी आ रहा है. You cannot start your video because the host has stopped it.
अच्छा, can I stop it?
So please check now, sir.
It is showing the same message.
पुनीत क्या करूं मैं? बंद कर दूं सब? फिर पूरा देखें शुरू से.
आपका सर नहीं. आई थिंक डॉक्टर सुबीर एक बार दोबारा ज्वाइन कर लेते हैं सर.
डॉक्टर घोष को बोलो ना एक बार बंद करके फिर से करें.
सर एक बार आप रीलॉग इन करके देखिए.
ठीक है सर.
आप मोबाइल से कर रहे हैं लैपटॉप से?
हेलो.
यस आपका स्क्रीन तो विजिबल है.
सर वीडियो नहीं आ रहा है. एक्चुअली वीडियो अभी भी सेम मैसेज
नहीं आ रहा.
नहीं.
वैसे अपनी वीडियो है सर. आप एक बार ऑडियो थोड़ा मे बी लाउडर बोलेंगे तो वैसे ऑडियो क्लियर है.
ठीक है
स्क्रीन.
ठीक. Sir, shall I start?
So please try now, sir. I think it will be done now. It is there, sir, now.
I'm presenting the case of a 21-year-old female, or a student of BCA, a resident of Uttam Nagar, New Delhi, who came with the complaint of swelling around eyes and bilateral lower limbs since 25 days. The history is provided by the patient herself and her mother. My patient was apparently asymptomatic 25 days ago when she developed swelling around both eyes, which she first noticed an hour after waking up in the morning. At first, she did not think much about it, but as the day progressed, she noticed that the swelling is also present in her bilateral lower limbs. This swelling was pitting in nature, was confined to her ankle joints only. Over the course of the next 2 days, she found out that the swelling subsides on lying down and increases with any kind of activity. During this time, she also complains of pain in the abdomen, which was dull aching in nature, present all over the abdomen, but did not hamper her daily activities, no aggravating factors, and was relieved by taking 1 tablet of paracetamol. During the course of the next 5 days, the swelling gradually increased, due to which she had difficulty in wearing her shoes, and she noticed that she is having frothy urine, as well as she noticed that the swelling did not decrease as much as before on lying down. After this, she sought medical help from a local practitioner. During routine investigations she remembers that she was found to be hypertensive. She remembers the upper limit of her blood pressure, which was around 160 millimeters of mercury. Her urine samples were taken, blood samples were taken, and blood sugar levels were checked. She was prescribed an antihypertensive medication in a twice daily dosing, and other medications, which she says increased her urine output a lot. According to her, the swelling improved a little, but did not disappear completely. After 2 days on visiting the same practitioner, she was told that her urine is leaking protein and her creatinine levels were increased, which were around 2.6 milligram per deciliter, and she requires referral to a nephrologist. Thereafter, she went to another hospital where further blood investigations were done, and she was asked to collect her urine for 24 hours. On 25th August 2021, she came to our hospital where after checking her coagulation parameters and routine investigations, her renal biopsy, native kidney biopsy was done on 27th August 2021. There is no history of oral ulcers, fever, arthralgia, photophobia, rashes, myalgia, alopecia, cough, sinusitis, rhinitis, purpura, petechiae, abnormal body movements, recurrent childhood UTI, nocturia, burning micturition, loss of appetite, loss of weight, yellowish discoloration of eyes, hematuria, hemoptysis, altered color of urine, alternative medicine intake, shortness of breath, paroxysmal nocturnal dyspnea, weakness, episodes of accelerated hypertension, or easy fatigability. Then past history, she says that she developed breathlessness 4 years ago, and her chest X-ray was done during this time. It showed right-sided pleural effusion, which was aspirated, and on subsequent investigations, it was found to be tubercular in nature. She took anti-tubercular drug therapy for 6 months and was in regular follow-up with the DOT center. There is no history of type 2 diabetes, coronary artery disease, asthma, blood transfusions, or any renal dysfunction in the past. Her personal history: she is unmarried, non-vegetarian by diet, normal bowel and bladder habits, no alcohol intake, no inhalation or chewable tobacco intake. Her menstrual history: she had menarche at the age of 12 to 13 years. Her cycle frequency is every 25 to 30 days, and the cycle duration is around 3 to 5 days. Family history.
Dr. Ghosh.
Yes, sir.
Dr. Ghosh, just hold on. What do you think with this history? What is your diagnosis? What is your clinical diagnosis?
Sir, my clinical diagnosis is, first diagnosis is rapidly progressive renal failure. Sir, rapidly progressive renal failure.
Okay.
First diagnosis is
what
this.
Do you think cause for the renal failure?
Sir, it can be acute glomerulonephritis, which can be, sir, lupus nephritis, IgA nephropathy, or post-streptococcal glomerulonephritis. Sir, it can be acute interstitial nephritis. And sir, then my second diagnosis is acute kidney injury on chronic kidney disease.
What was your first diagnosis?
Yes, sir.
Your syndromal diagnosis is RPG, and you are making. What you are telling? Rapidly progressive renal failure.
Yes, sir.
Hello.
Yes, sir.
You are making a diagnosis of rapidly progressive renal failure. That's all, no?
Yes, sir. Yes.
So, is there any history of decreased urine output? Is the patient told?
No, sir.
No. So, no, sir. Suppose you were not knowing the creatinine value, what she has told that creatinine was 2.6.
Yes,
then
sir.
what will be your diagnosis? Somebody presenting with swelling over feet and face and this progression. So it's your, anyhow, you complete your history.
Sir, it can be, sir, nephrotic syndrome, sir.
Yeah, that will be the first diagnosis you think. But now you are knowing the creatinine value because she was perfectly all right and creatinine is 2.6. Then you can say it's rapidly progressive renal failure.
Yes.
Because subsequently kidney function was not tested. It was tested in PSRI when she was admitted on 25th.
No, sir. Sir, it was tested around 20th from a local practitioner, sir.
No, but she was admitted in your hospital on 25th, I think.
Yes, sir. Yes, sir. Yes, sir.
So only one time to creatinine was on 2.6.
Sir, yes, sir.
Okay,
sir,
you tell me what other finding, whatever history you are telling, tell me, complete your history.
Sir, family history, there is no significant family history. And sir, in the drug history, she has no significant drug history, sir. Sir, the summary is, sir, she's a 21-year-old female with history of generalized body swelling since 25 days, and on subsequent evaluation found to have proteinuria, deranged creatinine level, hypertension, and underwent native kidney biopsy.
Okay, so your first diagnosis, you are making rapidly progressive renal failure. So what do you think the first possible cause in this case?
Sir, Sir, I am thinking about, firstly, I think about, sir, acute glomerulonephritis due to, etiological diagnosis is, sir, either, sir, it can be lupus nephritis because she belongs to the childbearing age group she's 21 years old, and it has a predisposition of 8:1 to 15:1 in terms of the female sex. Sir, then, sir, she has no extra renal features though. Sir, second, I have IgA nephropathy, which is, sir, because it is the most common glomerulonephritis currently in the world.
So first possibility, you will keep IgA or lupus. If the patient is having no extra renal manifestation, no history is telling. Definitely,
Sir,
young female, you will keep a possibility of lupus, but your first possibility will be IgA.
IgA, sir, IgA.
So you have to keep the first possibility IgA.
Yes,
okay.
Sir.
Then another possibility for rapidly progressive renal failure.
Sir, actually, the voice
is. You have not told me the urine.
The voice is cracking, sir.
Even I am hearing the very cracking voice, sir. Not able to hear properly.
Okay, sir.
What will be your second possibility?
Sir, second possibility?
Yeah, in rapidly progressive renal failure in this patient.
Sir, sir,
how a classical IgA nephropathy patient present first time in life? Is there any points in favor of history or anything?
Sir, a classical patient presents with recurrent episodes of macroscopic hematuria in 40 to 50% cases. Sir, she has no such history.
So she has no such history. She has no extrarenal manifestation history suggestive of lupus, no joint pain, nothing. No?
No, sir. No, sir.
So any other history of drug, any indigenous medicine intake, anything
no,
she
sir.
has taken?
No, sir.
Have you asked the history of medication?
Yes, sir. I have asked the history of medication. I have asked the history of any preceding infection. Sir, she gives no history.
Okay. So in rapidly progressive renal failure, you are keeping two possibilities. Either it's acute glomerulonephritis or it's a lupus nephritis. First time presenting.
Sir, third is, sir, I have kept PSG and also, sir, a post-streptococcal glomerulonephritis, infection, sir, related glomerulonephritis.
What is the natural history of PSG?
Sir, PSGN usually.
PSGN patient present?
Sir, a PSGN patient usually is, sir, younger. Sir, in adults it can also present. In adults, sir, 20% cases can present with nephrotic syndrome. Sir, 80% patients present with renal dysfunction, 80% patients present with hypertension, and sir, 35 to 40% patients present with oliguria or edema.
But she doesn't have any history of sore throat, any previous history,
no, sir.
Nothing. She was totally healthy.
Yes, sir.
No history, nothing.
No,
okay.
Sir.
So you tell me your examination finding.
Sir, in physical examination, the patient is conscious, alert, oriented to time, place, and person. Her weight is 65 kilos, height is 170 centimeters, BMI is 23.89. She is lying comfortably in supine position. Her pulse rate is 86 per minute. It is regular, normovolemic, synchronous. All peripheral pulses were palpable, and there is no radioradial and no radiofemoral delay. So the blood pressure is 130 by 60 millimeters of mercury in right arm supine position. In standing position, it is 126 by 60. It is 130 by 60 millimeters of mercury in left arm supine position. Sir, there is no pallor, no icterus, no
this
cyanosis.
Medication? For
Sir.
blood pressure, is she was taking any medicines in your hospital?
Yes, sir.
Or blood pressure is what
Sir,
medication she was having? You don't know.
Sir,
she doesn't know. Okay.
Sir, she doesn't know in terms of history, but in the hospital, I know, sir, which medication she was.
Okay. Okay. You tell me other finding, examination finding.
Yes, sir. Sir, there is no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy. There is edema present in bilateral lower limbs, which is present up to 5 centimeters above the medial malleolus. Sir, the fundus is a normal study. Then, sir, sir, there is actually in the systemic examination also, sir, there is no positive finding.
So what will be your urinary finding that come also in the examination?
Sir, yes, sir. Sir, my urinary finding was that she had a pus cells, sir, albumin of 3+. She had a granular cast present. Sir, pus cells 8 to 10 per high power field and RBCs of 10 to 15 per high power field.
Granular cast present, pus 8 to 10, RBCs how much?
Sir, 10 to 15.
So you only you are having positive findings in urine examination, no?
Yes, sir.
So with this urine examination, now you tell me your differential diagnosis.
Sir, I would like to give the possibility of IgA nephropathy first. Then, sir, I would like to give.
Tell me, hello, why?
Sir, because she is having
points in favor.
Sir, 40 to 50% cases of IgA nephropathy present with microscopic hematuria only. Sir, sir, that is why, sir. Then I can present. I am keeping the diagnosis of post-streptococcal glomerulonephritis. Sir, she has a.
No. Don't jump from IgA to.
Yes, sir.
Listen.
Yes. Yes,
don't
sir.
jump from IgA to post-streptococcal.
Yes, sir.
You are keeping a possibility of IgA. How many percent of patients they present with the renal failure in IgA?
Sir, around sir 5% of patients present with acute kidney injury in IgA nephropathy.
So why you are making first diagnosis IgA? You are knowing that her creatinine is 2.6. You told me, na?
Yes, sir.
6-7 days back, creatinine was 2.6. Now this urine is active urinary sediment.
Yes, sir.
You tell me your first possibility with renal failure, with active urinary sediments. Your urine sediments are active, no?
Yes, sir. Sir, sir.
There is no RBC cast, only granular cast you are telling, no?
Yes, sir.
Have you examined yourself?
No, sir. This is the lab report.
Have you done your urine examination by yourself?
No, sir. It is the lab report.
Hello?
Sir, it is the lab report.
In such a patient, Dr. Ghosh, you must do the urine examination because the urine examination will tell everything.
Yes, sir.
Suppose this urine examination will be full house presentation, RBC cast, WBC cast, everything, then what will be your diagnosis?
Sir, telescopic urine, sir, lupus nephritis.
So then your diagnosis will be clear. Suppose you are getting RBC cast, granular cast RBC cast may, suppose the urine sample is delayed in testing and all this, and you may get RBC cast into converted to granular cast. So this, your urinary findings suggestive of active urinary sediments. So then yes, you can keep a possibility of PSGN. That is all right.
Yes, sir.
Okay. Because
yes,
presentation was sometimes subclinical infection can cause PSGN, and she was a young patient, sudden onset history within five days of history with generalized swelling and deterioration in renal function. Okay.
Yes, sir.
So that is you must keep possibility or possibility PSGN.
Yes, sir.
Then what are the other causes for the rapidly progressive glomerulonephritis?
Sir, for rapidly progressive glomerulonephritis, first it can be, sir, depending.
You agree now? Your diagnosis syndromal diagnosis is RPGM, with urinary finding. Fine.
Yes, sir. Yes, sir.
Nephrotic syndrome. What do you think?
Sir, this is sir, rapidly progressive renal failure, most probably related to RPGN, sir.
Okay. So what are the causes of RPGN?
Sir, RPGN can be divided. The causes of RPGN can be divided on the basis of the, sir, immunoglobulin deposition. Sir, if it is linear, sir, in the first group there is anti-GBM disease. Sir, in the second group there is immune complex mediated disease, sir, which is more likely IgA nephropathy. IgA vasculitis,
Mhm.
sir, lupus nephritis, PSGN, cryoglobulinemic vasculitis, and sir, fibrillary glomerulonephritis, and sir, it can be idiopathic. Sir, then the third group is sir, post-immune deposits, which includes granulomatosis with polyangiitis. Then it includes eosinophilic granulomatosis with polyangiitis and microscopic polyangiitis. Sir, then
What do you think?
yes, sir.
To which group this your patient comes? What do you think?
Sir, in the second group, sir.
Yeah, infectious diseases. So
Yes,
you can
sir.
keep one possibility of infection. And second,
Sir, second, sir, I can keep as sir due to sir she is presenting with renal dysfunction, sir. I can keep lupus nephritis, sir.
anyhow, young patient first time presenting, you cannot rule out the lupus. You must keep the one possibility of lupus. But this urine finding, suppose you do the estimation of urine proteinuria. How to estimate
Yes.
the proteinuria?
Sir, I will
Your
do
RBCs are you are telling pus cells are 8 to 10, RBCs are 10 to 15, right? You are telling
Yes,
this
sir.
thing.
Yes, sir.
You are just telling granular cast occasional. Hello.
Yes, sir. Yes, sir.
Occasional. There is no RBC cast.
No, sir. The only granular cast.
So that is the thing which is against RPGN. Then albumin you are telling 4 plus.
Yes, sir.
So what will be the another nephrotic syndrome possibility? Why not? It is a simple case of nephrotic syndrome.
Sir, it is because sir, it is she has having sir renal dysfunction and sir hypertension.
Yes. Okay. So then you more keep a possibility of PSGN will be first possibility. You want to rule out lupus, and second, of course, then how you do the estimation of the protein in the nephrotic syndrome with this urine? Have you done the further test?
Yes, sir.
Okay, tell me
Sir,
your urinary findings. How much is proteinuria?
Sir, I have
What was the WBC?
a slide on all the investigations that have been done, sir. Can I show?
You can show me or you can read me. I can't see
Yes, sir.
anything here.
Okay, sir. Sir, the CBC is in the CBC. Sir, the protein, if talking about protein first, the 24-hour urine protein creatinine ratio is 6.66, sir.
So it's
And
significant proteinuria.
yes, sir.
Just a minute. Now I can see your reports. Platelets 30, hemoglobin 10.3, creatinine 3.5, LFT total. No, yeah. You tell me how you will investigate this patient. Okay, tell me. You have written everything, but how you will start your evaluation with this patient? Suppose you are the treating physician.
Yes, sir.
Keep it here
first
only
I will.
investigation. Don't show too much. Yeah.
Yes, sir. Sir, first I would like to get a sir CBC done. Sir, along with incomplete blood count, I would like to get a liver function and a kidney function test done. Sir, then I would in this patient like to get 24-hour urinary PC ratio done. Sir, then I would
How
like
much
to
is
get
urinary? Your urinary protein ratio is 6.6 gram. It's a massive
yes,
proteinuria.
Yes, sir.
Can you get this much proteinuria in a patient of renal failure with PSGN?
Yes, sir.
You can get.
In 20% cases, sir, in adults we can get.
Yeah, but a little bit it is a rare, such a heavy proteinuria, but you can get. Okay, anything? Tell me other test.
Sir, then I would like to get ANA by immunofluorescence done. Sir, sir, rule out the cause of RPGN, sir, I would like to get an anti-dsDNA, a CNCA and a PNCA, and sir, sir, anti-GBM, sir, antibodies, and sir, C3 complement level and the C4 complement levels.
Just hold on. Why you will do NCA in this test, in this patient?
Sir, I will do NCA because, sir, there is a possibility of renal limited vasculitis also, even though she belongs.
At this age, you will get.
No, sir, it is more common.
This, how common at this age?
Sir, it is more common in 60 to 85 age group. It is, sir, in this age.
So she is 21. She is 21.
Yes, sir.
We are doing on workup, that's all right, but you will not get importance. You do the, what other tests, important tests you have not told me to do if you are suspecting PSG and first diagnosis?
Sir, urine culture, sir.
छोड़ो, और क्या करोगे?
Sir,
PSGM में?
streptozime test,
Yes.
sir, कर सकते हैं.
हाँ, तो have
Sir,
you done
there,
ASLO titer? Have
no,
you
sir.
done?
No, sir.
That is the first test you have to do, ASLO titer. No? If you are suspecting and patient is also fitting in your PSGM. Okay?
Yes, sir.
So you must do. Then you do the C3 complement level, C3, C4.
Sir,
Suppose
yes,
it's
sir.
lupus,
C3 is,
what happened to C3? What happened to C4? If it is lupus?
Sir, it can be either low C3 with normal C4, or it can be low C3 and low C4, sir.
Especially you see for the C3, the low C3 you will. So your C3 is low in this patient.
Yes, sir.
78 you have written. No?
Yes, sir.
Okay, but ANA is negative, dsDNA is negative, MCA is negative. You have not done the ASLO titer. Huh?
No, sir.
So what other tests you have done?
Sir, we have done a
platelet counts were normal. Pardon?
So urine culture we got
Where?
Sir, it was negative substance.
Yeah, UTI also, the urine culture is trial. There is no growth.
No, sir.
Then have you done ultrasound?
Sir, actually, sir, the patient has financial constraints. So, sir, we did not do a ultrasound on ourselves, but we did an NCCT KUV, which was, sir, we did not do it. Basically, the other hospital had done it, so we went with that report. So it is showing right kidney 10.6 centimeter, left kidney 10.6 centimeter, and sir, there is no stone, there is no hydroureter nephrosis, there is no perirenal fat stranding. And sir, it had lobulated contour with these findings, sir, and nothing else.
You must have done biopsy, I hope, under ultrasound guidance.
Yes, sir.
Hello?
Yes, sir, I have done.
So that time you can see the ultrasound findings.
Yes, sir.
Okay, then she underwent renal biopsy.
Yes, sir.
Okay, tell me findings.
I think we can hold on, Kailash. Let's have some discussion.
Sir,
I'm enjoying
please.
I'm listening to the discussion. Of course, I missed the initial part, so I don't know, and if I may be pardoned for the same.
Sir, I will request him to tell the SART history.
Yeah, so I think
Dr. Ghosh,
yes,
can you tell the SART history?
Sir, she's a 21-year-old female with history of generalized body swelling since 25 days. And on subsequent evaluation, she was found to have proteinuria, deranged creatinine level, hypertension, and underwent native kidney biopsy.
No, there was some talk of some infection as well. So what was that infection? Sorry,
Sir,
come again, please.
Sir, basically, sir, she has no history of infection. Sir, the first diagnosis was sir kept as the diagnosis was kept.
No. History again, please. Soubeer, I think I'm missing a point here. So that's the reason. Can you show me your first slide where you would have written the chief complaints and?
Sir, I have verbally told the history. This is just one slide.
So swelling around eyes and bilateral lower limbs for the past 25 days, is it?
Yes, sir.
All right. And no fever?
No, sir.
No fever?
No, sir.
Okay. And then she came and you investigated and found that she had this thing. Okay. Anything else? Anything important in the history? Joint pains or rash or alopecia or malar rash or?
Sir, I can go through the negative history again.
No, this is fine. So I don't want to waste everyone's time. So I think if this is it, maybe you can stop sharing your slides and let's have like a classroom where everyone is around. So let me go through the gallery view and then pick up people with their suggestions about this thing. So can you, may I request you, Soubeer, to stop sharing your screen and maybe you can come back finally with the biopsy report, all right? Okay, so let's, okay, so now that's better. So everyone, no one really wants to show their face today, I believe. So let it be. If few of you can volunteer. I think I always feel better when it's not like a robotic kind of class where you don't even know who you are addressing. So if people who are in a position to unmute their the audios and the videos, and then probably we can face each other. Soubeer, you were talking about PSGN, and I think there was some discussion about PSGN. So let me ask a few questions. Based on what you have shown, because I did join you when you were showing the reports, you said there was proteinuria. Did you show some albuminuria as well?
Hello?
I think you.
Hello?
Hello?
Sir, I actually got, sir, I went, sir, the app shut down, sir, actually.
Okay. Oh, sorry.
Yes, sir. Yes,
Okay.
sir.
Now, can you I mean, one more time, tell us about the urinary findings. Was there albuminuria? Was there hematuria as well?
Sir, there was a 3+, albumin was 3+. Sir, there was a granular cast present. Sir, pus cell was 8 to 10, and sir, RBCs were 10 to 15.
Okay. So let's dissect it one by one. What are the clues? Soubeer, what are the clues? The patient comes to you with possibly a glomerular disease, right?
Yes, sir.
Now, based on the history and based on your investigations which you had shown us, what are the points?
Sir, basically she has, sir, hypertension. She has proteinuria.
Yes.
Then she has deranged renal function. Along with
no, I'm referring to something else. Will you call it a nephritic illness? Will you call
Yes.
it a nephrotic illness? Will you cause it a rapidly progressive glomerulonephritis? So first, let's begin from there.
Sir, I would like to call it a rapidly progressive glomerulonephritis.
Do you think there's an entity called nephrotic illness as well? You said the proteinuria was 6.6 grams.
Yes, sir.
6.6 grams proteinuria, active urinary sediment, 10 to 12 RBCs, all right? And a creatinine of 2.5.
Yes, sir.
We don't have history whether this creatinine has been rising or has been static or has been declining.
Sir, it has, we have a history, sir, in the form that when she went to a local practitioner first, her creatinine was 2.6. And when she went to came to our hospital after 5 days, her creatinine was 3.5.
3.5, right.
Yes, sir.
So quite a progressive disease. Within a week, you would say it had gone up from 2.6 to 3.1. It could fit both with an acute insult, an AKI kind of insult, or it could fit with rapidly progressive insult as well.
Sir, the patient has symptoms since 25 days. Sir,
okay.
Yes, sir.
Yes, so you could be right. I'm not contesting your diagnosis of
Yes,
RPGN, you said, right?
Yes, sir.
Right. So what is the clue which takes you away from RPGN in your investigations? Because there is not much, as you since I joined late, I don't know much about the history, but there is one clue in the investigations which takes you a little away from RPGN. What is that clue? Anyone? Just unmute yourself and come out with that this thing. So can we? Let me see the view.
Nephrotic range proteinuria.
No, that can be there.
Yes,
with I think ये या तो आप share कर रहे हो, इसको आपको share बंद करना पड़ेगा. I think that must be the reason.
Sir, actually share बंद करते ही मैं सर ऐप से बाहर जा रहा हूँ.
Oh, अच्छा, okay. So anyone? One more minute before anyone can. Who can tell us? What is that clue?
Sir,
Sameer says preserved urine output. No, that's again not something against any of the diagnosis. You can have preserved urine output till quite late in any form of renal disease.
RBCs in the urine.
RBCs is if you didn't have RBCs, you shouldn't even have kept the possibility of RBCs.
No. Yes, sir.
So what is one thing? Anyone? I was expecting from at least granular cast, hypertension. No. Hypertension is a relative thing. We tend to at times believe that hypertension may not be a very uniform feature of RPGN, but then by the time disease progresses, you see that hypertension comes in a vast majority of cases. So, well, in a way, Arpit, you are right, but then the practical situation tells us that the majority of the times hypertension is there. Anything else? So I thought everyone would tell me that. What is the C3 value?
Sir, it is low, 78.
So what do you expect in RPGN? Low C3? Do you?
Sir,
Do you expect low C3 in RPGN? And if yes, in which variety and what excludes?
sir, we can expect low C3 in lupus nephritis.
Yes,
RPG.
so there are subtypes of RPGNs where you would expect a low C3,
Yes, sir.
and those are one.
Sir,
You
yes,
see, start from Mehak Singla says immune complex. Well, yes, it's right.
sir, we can
If
have
you no, listen me out now, because this should have come up, come from majority of the people who have joined us today. In primary RPGN, you don't expect a low C3. I mean, anything can happen otherwise, but the common variety is not. So whether you talk about anti-GBM disease, or you talk about post-immune disease, or you ANCA-associated RPGN, all right, IgA nephropathy associated RPGN, you will not get a low C3. While in lupus nephritis, in PSGN related, in Henneke-Schwann purpura, in shunt
Okay.
nephritis. So these are the varieties where you can have coexisting RPGN and low C3. So I hope I'm clear the point I wanted to make. In the Gardner variety RPGN, where we typically associate it with either a post-immune or anti-GBM, and in a few of the immune complex. So the answer was right, that immune complex is one. Shashank says C3GN, absolutely correct. C3GN or MPGN with crescents, C3 glomerulopathy, PSGN we've already said. So these are the varieties where you will get a low C3. So if you are expecting crescents in her biopsy today, and you already have a low C3, and mind you, you had a low C3 but normal C4. So it's an alternative pathway, which is in effect in your patient. All right.
Yes, sir.
So what else comes to your mind when you have a patient with nephrotic illness and a low C3?
Sir, atypical HUS.
Atypical HUS. Yes. So how will you now differentiate this entity from the various diagnoses which you've kept so far? What are these?
Sir, we can go for ANA by IF. We can go for anti-DS DNA, ANCA-C, ANCA-P, and sir, we can go for kidney biopsy, sir.
नहीं, किडनी बायोप्सी बाद में होगी, अभी तो कुछ तो क्लू करोगे ना आप, right? So हमें आप डिस्कशन हो रही थी PSGN की थी. Even though, so these are very important things, and nephrologists cannot go away from without knowing the nitty-gritties of PSGN.
Sir, we can get in PSGN, we can get we can get simultaneous ANCA positivity. We can get positivity for anti-C1q antibodies. We can get positivities for rheumatoid factor. We can get positivity for cryoglobulins. And
This is किसमें आप कह रहे हो पॉजिटिव हो जाएगा?
सर PSGN में ये 25% प्रोबेबिलिटी के साथ सर मिल सकती हैं.
देखो, पहली बात, PSGN means streptococcal. To say that PSGN happens in a 21-year-old, I'm not saying it cannot happen, but this is not the age typically of PSGN. PSGN typically you will see in
Children,
younger,
sir.
right? In children. And there is a lag period. Even if you wanted to bring in PSGN, you know that there is a lag period. There's a latent period between catching infection and getting PSGN. So that's typically 1 to 2 weeks if it is post-streptococcal pharyngitis, or
4 to 6 weeks, sir.
4 to 6 weeks if it's a skin-based infection.
Yes, sir.
What would be, if you have to bring in a possibility of infection, what would you bring in? PSGN or something else? Before we move on to the next, have you heard of SAG? Not as what the gastroenterologist says, but not the sarson wala SAG, but the nephrologist wala SAG. What is that? Anyone?
So schistosomiasis associated glomerular nephritis.
No. Something much more commoner.
Sir,
Anyone? This thing? So हम हमेशा
staphylococcal.
Yes, very nice. So why not keep a possibility of staphylococcal associated acute glomerulonephritis, right?
Yes,
so there, how do you differentiate that from PSDN? Any clues? Of course, the ASO titer will be negative. Of course, there may not be any history of a forgotten episode of infection, right?
Yes, sir.
But what you get is a concomitant. The way you get pharyngetic illness in IgA nephropathy, you get at the time when one has a staph infection, you get acute glomerulonephritis as well. What happens to complement level there?
Sir, C3 is low.
The complement level is low, and typically it's alternate pathway. You have low C3, but normal C4. So both C3 and C4 can also be reduced, suppressed in patients with staphylococcal associated glomerulonephritis. That means the classical pathway can be stimulated in about 10 to 20% cases, but in 80% it is. So another differentiating feature is when you look at the immunofluorescence in PSGN, you get
there will be mesangial IgA deposition.
IgA, you get C3 levels as well. Here you have predominant IgA. So this is the differentiating feature from staph associated. And when you talk of adults, you will rather keep a possibility of staph. Now, that does not mean that I'm keeping a possibility of staph. This was just to tell you people that you should also keep a possibility of SAG rather than PSGN, which we tend to speak so very often. All right?
Yes.
What is against IgA nephropathy in your patient? You know, one of the commonest presentations, commonest diseases of this age group would be IgA nephropathy.
In 50% cases, sir, IgA nephropathy presents with recurrent episodes of macroscopic hematuria.
Doesn't matter. No, I'm not asking that. Let's go back to your patient. Your patient presented to you with edema, has proteinuria, has RBCs. So far, you would say that, oh, it fits best with IgA nephropathy. Now, what subsequently have you figured out which says it may not be IgA nephropathy?
Sir, IgA nephropathy presents with renal dysfunction in only less than 5% cases.
Very correctly says, and I think you can read on your screens, Vivek says the nephrotic syndrome is a less common presentation. But again, Vivek, you must remember, it may be less, but then you still do get nephrotics even with IgA nephropathy, correct? But more important is you don't get low C3 in IgA nephropathy. Okay, you can get low C3 in Hennig-Schwann and purpura, but you don't get low C3 in IgA. Unless you say, I don't believe in IgA, I don't believe in C3, that's a different story. But if you are going to give importance to this thing, so here your patient has a low C3. So Vanna wanted to say something. Vanna, I think the C3 was low in this case. So that is probably this thing. And then again, Mohit, I would not say that absence of RBC cast will take you away from a possibility of IgA nephropathy. I believe it could still have been IgA nephropathy, but I would tend to believe that the low C3 has to be given importance unless your patient of IgA nephropathy gets superimposed staphylococcal infection or some other infection which can cause this kind of, or it has some kind of superimposed crescentic transformation because of some infection. This IgA nephropathy with synpharyngetic infection even if it has crescentic transformation, still the C3 is likely to remain low. So that is the kind of importance I would want to give to C3. So maybe the take-home message of today's class would be the due importance you need to give to complement level C3 as well as C4. I hope I'm clear.
Yes.
Now let's move on. And you haven't kept the possibility, once you haven't done a biopsy, let me tell you, all this discussion is before you actually did a biopsy. Okay? Before you did the biopsy, you had the report of C3. Why haven't you kept a possibility of C3 nephropathy? 21-year-old girl, nephrotic stained proteinuria, which I am typically say when you refer to something called nephrotic illness. So the things which come to your mind are PSGN or IRGN, infection-related glomerulonephritis. It could be any infection. All right. One.
Sir,
it could be membranoproliferative glomerulonephritis.
Sir,
it could
the
be
DD I said was on the basis of history, sir.
No, agreed. I'm not saying that. Now you can revise your history based on the investigation, because since you said there is not much in the history, so obviously we are having to rely on the same. All right. So what is against C3 nephropathy? All right. And now finally, what is the most likely diagnosis which you will never ever want to miss in a 21-year-old lady? What is that? We're talking about her being a childbearing age.
Sir, against C3 nephropathy, we can keep.
Sorry, C3 nephropathy?
Sir, lupus nephritis.
Yes.
Sir, lupus nephritis.
So, सबसे पहले common चीज है lupus nephritis. What is against lupus nephritis in this patient? If I tell you, sorry, what is against?
So there are no extrarenal features, sir.
You may not have extrarenal features. What is the latest classification of lupus? The ACR-ULAR classification.
Yes,
what is it?
Sir, firstly, there is a constitutional factor, sir, constitutional symptoms in which, sir, there is firstly, it is fever of more than 38.3 degrees Celsius, which is given a score of sir, 2. Then there is musculoskeletal system in which, sir, there is
so let's talk about the most common criteria. 1 is to 80 or more above of ANA positivity.
Yes, sir, on average. Yes.
ठीक है. ये तो एक एंट्री क्राइटेरिया, ये तो होना ही होना है. उसके अलावा अगर इस पेशेंट को मैं कह रहा हूँ सिर्फ और सिर्फ क्लास 4 lupus nephritis आ जाता है on biopsy, she gets 10 points.
10 points, sir.
She gets 10 points.
She gets
Do you think? ठीक है? So why not lupus nephritis now?
Sir, yes, sir. I have kept a possibility.
So don't wait for the skin manifestations, which are going to be there in majority of the cases, but not all. Don't wait for those arthralgias or CNS manifestations or the thing. All right.
Sir,
so,
but
so
I think
the way I often tell everyone, all of you, whenever get a chance to, never ever go away from the possibility of lupus nephritis in young females and of multiple myeloma in any elderly. Nikle na nikle aur baat hai, but you will be failing in your duty if you do not keep a possibility of everything. All right.
Sir, but class 4 lupus nephritis will be finding on biopsy only, sir. Sir.
मैं कह रहा हूँ आपके पास एक 21-year-old फीमेल आई.
Yes, sir.
Right? आपके पास और कुछ नहीं है.
Yes, sir.
आप उसकी बायोप्सी कर रहे हो. So I'm giving you a hypothetical situation कि अभी आपके पास कोई investigation नहीं है. Tomorrow ANA will come as positive, and day after tomorrow the kidney biopsy will say that's class 4.
Yes.
Right? और उसमें अब एक और criteria आपको चाहिए. All right, and this becomes a SLE. SLE. So we have still now, let us sum up. Based on the history and based on proteinuria, microscopic hematuria, 6.6 grams of proteinuria, ANCA negative, and low C3, we must now narrow down our possibilities. So what are your possibilities? Well, finally, हम biopsy देखें. उससे पहले you should have kept or considered all these. Now we'll give you some time to come out with your most likely diagnosis, what you're going to see on kidney biopsy based on what we have summed up so far. everyone has a right today to disagree. So why can't someone just unmute yourself and say, no, this is what I want to say, right? Yeah, this is much better. Yeah. Anyone? So let me see the chat messages. में कुछ हमने मिस तो नहीं किया? Clash, आप देख पा रहे हो chat messages? Clash? Dr. Clash is there? Dr. Clash?
हाँ, yes sir.
So कोई और messages? Yeah, any other point at अभी इस level पे? Point of discussion?
I don't think so, sir. Let him tell the sir kidney biopsy report.
मेरा ख्याल अभी एक बारी Clash उससे पूछते हैं. I just wanted him to sum up the various possibilities in the order of occurrence. So आप बताइए,
Dr. Ghosh. Hello.
I think वो connection कट जाता है उसका जब वो share करता है, stop करता है. नहीं, he's back. Soubeer. Now Vivek says that FSGS is a possibility. So you will have to unmute yourself, Vivek, and
Yes,
defend
sir.
your rights.
Yes, sir. Sir, it's an adult female who's presented to us with a nephrotic syndrome, and she has an active urinary sediment in the urine examination. So, sir, most common cause of adult onset nephrotic syndrome being FSGS, and it could be having an active urinary sediment as well as it could be associated with hypertension as well. So, sir, though not maybe at the top of the order.
Agreed.
Not, sir, C3 would not go. Of course, low C3 would not go with it.
Yeah.
But
So
yeah, just from the presentation.
Today, agreed. But we are now summing up based on the inputs we have so far. So I don't think I would want to keep a possibility of FSGS.
Yes, sir.
Based on the history, yes, certainly.
Yes, sir.
A malignant FSGS, why not? RBCs, hematuria is certainly not against this thing. But then we now have the value of C3.
Yes,
so I would not want to keep FSGS as a possibility. Secondly, FSGS will not be this kind of fulminant FSGS in a vast majority. We see a lot of FSGS. That gives you time. Unless, let me tell you, FSGS causing a creatinine of 2.6 going up to 3.5. It cannot be a natural progression. So there has to be an acute element. You do not expect crescents in FSGS. So how can you account for a creatinine? This again is for the sake of everyone present here. How would you imagine FSGS behaving? So I'll tell you that FSGS will take two kinds of courses. One is a malignant course, which is not seen very often, thankfully, but that is typically where you will get a lot of edema, a very heavy proteinuria of something like 10-15 grams, very severe hypertension, and a
hypercholesterolemia.
Depend course. And let me tell you, based on my own experience, I don't know how many of you would agree with that. There will be some subtle tubular defects, and you can actually get renal glycosuria. So if in a 21-year-old you get renal glycosuria, always think of FSGS as one of the possibilities. I'm not saying the only possibility, think of FSGS as well. But certainly, you stand corrected, Vivek. FSGS not with low C3, because the discussion today, I'm trying to focus more on what kind of information can you derive from such an important tool that is C3, C4. All right.
Yes.
So, Soubeer, you have had some time. Now you will need to tell us, a 21-year-old female presenting to you, based on the history and based on the investigations,
Yes,
आप क्या रखना चाहोगे possibilities 1, 2, 3, 4?
Sir, one, I would like to keep C3 glomerulonephritis.
No, syndromic diagnosis.
Sir, we can keep syndromic diagnosis will be acute glomerulonephritis. Then we can, in etiological diagnosis, we can keep C3 glomerulonephritis. We can keep PSGN, sir, we can keep lupus nephritis, then PSGN. And sir, yes, sir, this is what
MPGN. MPGN क्यों भूल जाते हो आप? थोड़ा fairly common है वो, इतना बुरा भी नहीं है वो, right? So MPGN type 1.
Yes, sir.
So I'm not saying MPGN type 2, or I'm not trying to confuse you with C3 nephropathy.
Yes,
But
sir.
then why not type 1 MPGN? The age is not against, although again थोड़ा सा बच्चों में ज़्यादा और थोड़ा सा होता है, but 5 to 30 is the age where you can expect MPGN type 1.
Sir,
Okay.
there is no history of any lipodystrophy or anything.
No. That's very, very rare. I mean, partial
Yes,
lipodystrophy, and it's a very rare entity. Don't club MPGN is a fairly common entity. It's not
Yes, sir.
obviously it is not as common as IgA nephropathy or lupus or your membranous or lupus. But then, if you've talked about the common things, the next thing would be MPGN.
Yes, sir.
Right. Okay. Anyone else? So I hope you mentioned lupus nephritis this time.
Yes, sir. I have my second diagnosis.
You could expect this thing, and any surprise if I tell you, could it be Alport's?
Sir, she has no history of any sir difficulty in hearing any hearing loss.
Again, that was the catch, Soubeer. The history may be lacking.
Yes, sir.
History may be lacking. So you don't have to say that the patient is not wearing specs, is hearing my conversation quite this thing. That means she doesn't have any hearing of this thing. But how often do you see, it's an X-linked disease, how often do you see a 21-year-old Alport syndrome presenting to you with end-stage kidney or advanced CKD? Right? So it can happen, but is not the common presentation of an Alport. The Alport was kept in mind, or Fabry, so that you would have thought of these rare things as well before you say, okay, अब मैंने सारा सोच लिया और कुछ नहीं निकलेगा, मेरी बायोप्सी में, इसकी बायोप्सी में ये मेरे 4-5 डायग्नोसिस में से क्यों निकलेगा? So I'll be quite surprised if it turns out to be anything apart from this. Dr. Kailash?
Yes, sir.
आप बताइए इनको थोड़ा और क्या आपको लगता है इसके अलावा?
I think looks like lupus nephritis, sir. The way he is presented, and that is the one possibility, sir, from my side. And second, still I'll keep a IgA nephropathy with crescentic glomerulonephritis.
Right, तो बात वहीं आ जाती है. That means कि C3 की importance फिर हम कम हो जाएगी. So that's one. And
but ANA and other MPGN is another possibility, sir. Yeah.
But you said ANA is negative, Soubeer.
Yes, sir.
So again,
ANA, dsDNA is negative.
if you have done it with the sensitive assays, the ANA is negative.
So ANA by immunofluorescence is negative.
So I think SLE भी आप नीचे आ जाती है, right?
Yes, sir.
So we'll consider possible. So anyone, so let me one more time see the chat box. किसने क्या लिखा है? Sameer says it's female. I agree with that. And क्या है? Lupus, ANA is negative. ANA, DDD, yes, DDD. Okay, but all right. Anyone?
Dr. Ghosh, what is against? Dr. Ghosh, what is against acute interstitial nephritis?
Sir, she does not have any preceding symptoms of polyuria, nocturia. Sir, sir?
No, not necessary.
Sir, she does not have any history of taking any sir, drug, or sir.
That is important.
Yes, sir. She does not have any extrarenal features again, sir. She does not have any history of fever, sir.
Okay.
एक और क्वेश्चन आया अभी, मोहित ने पूछा है nephrotic range proteinuria in Alports. Well, Mohit, nephrotic range proteinuria can be seen in Alports. In fact, I'll tell you, so many times the diagnosis gets missed. I'll tell you at least of 2 families where it was mother first who was on my treatment. We treated FSGS on the lines of a primary FSGS, and she achieved partial remission with steroids. So the possibility of Alports was considered only when her son presented to me with nephrotic syndrome. He also improved with tacrolimus, not with steroid, but with tacrolimus. But when he recurred and then the problems resurfaced, we got the genetic test done, and it turned out to be Alports. So, and we've had a similar case, and I think Gangaram also had presented last time, so they also had a similar case. So it's a nephrotic change. Proteinuria can be seen in Alports as well, and there are instances whereby even Alports improved with cyclosporin or CNIs. So there is a special subset of called 4A5 mutation which can actually respond to CNIs. Now, Sameer wants to know, can C3 never be low in IgA nephropathy? तो Sameer, ये तो वही बात होगी, ये शेर जंगल का राजा है, उसकी मर्जी है, कभी हो जाए कम तो हो जाए. But I'm only talking about more common things. So rare things इस common platform में नहीं हम discuss करते. Rare को कुछ भी हो सकता है, but then yes, IgA nephropathy is not synonymous with low C3. But does that mean that C3 IgA nephropathy has nothing to do with C3? What is the pathogenesis of IgA?
So basically, there is, sir, first of all, there is accumulation of galactose deficient polymeric IgA1. Sir, then there is a production of IgA-G and IgA antibodies.
Yeah, मैं endpoint कह रहा हूँ. कौन सा?
Mesangial. Yes, sir.
वो बात में उस पे नहीं हम जा रहे. मैं कुछ और पूछना चाह रहा हूँ. क्या complement pathway disturb होता है in IgA nephropathy?
Yeah, होता है सर.
तो C3 low क्यों नहीं होता?
Sir, alternate pathway, sir.
तो भी तो C3 low हो
होगा सर. नहीं सर, I know.
नहीं होता ना. Membranous में complement pathway affect होता है?
सर, C1q की staining मिल सकती है सर, secondary membranous nephropathy.
Staining तो मिलती है, but complement levels कम होते हैं membranous में. So the take-home message today is, and that's in response to Sameer's query, IgA nephropathy and membranous nephropathy, two of the commonest things which you see as glomerular diseases, are not associated with low C3, even though they have, even though there is complement activation. So आपको पता है जो नया treatment जितने भी आ रहे हैं, they are targeting in IgA nephropathy as well as membranous nephropathy, they are targeting the complement pathway. Right? ये हम कभी बाद में कभी discuss करेंगे. Okay. So over to you, Soubeer. आप बताइए कौन सा biopsy की finding?
Sir, renal biopsy is a specimen containing 24 glomeruli, 4 out of which are globally sclerosed. Few appear enlarged and exhibit variable mild to moderate increase in mesangial hypercellularity. Few glomeruli show segmental endocapillary hypercellularity. Focal periglomerular fibrosis is noted. There is no crescent formation, tough necrosis, congophilic deposits, or intracapillary thrombi. Interstitial fibrosis and tubular atrophy are around 30 to 40% of sample cortex. Scattered large hyaline, granular, and few RBC casts are seen in tubular lamina. Dense multifocal chronic interstitial inflammation, including plasma cells, and focus of interstitial granulomatous reaction present. Direct immunofluorescence staining pattern, IgA negative, IgG 2+, 2, 3+, along mesangial and capillary wall, IgM negative, C3 2+, mesangial and capillary wall, C1q negative, kappa trace, lambda trace. The impression is mesangial and focal endocapillary proliferative glomerular morphology. Direct immunofluorescence reveals glomerular, mesangial, and capillary wall staining for IgG and C3, and dense multifocal chronic lymphoplasmacytic interstitial inflammation and focal epithelioid cell granuloma formation.
So, how are you wiser with this biopsy report? So, what is your diagnosis now? What you have seen on biopsy?
Sir, first I would like to keep resolving PSGN. Second, I would like to keep C3 glomerulonephritis. Sir, then she has a history of sir. I can't explain the focal epithelioid granuloma formation. She has a history of tuberculosis in the past, which I told in the past history that she underwent dural tapping for it, and she took ATT for 6 to 9 months. But the granulomas present here are non-necrotizing, sir. So the granuloma formation is a dilemma, but for the mesangial and focal endocapillary proliferative glomerular morphology with staining for IgG and C3, I'll go with resolving PSGN and C3 glomerulonephritis.
So the important thing to be noted here is the IFTA is 30 to 40%. There is a significant chronicity. And even the interstitium contains a lot of chronic inflammation. So there is a lot of chronicity here. So it's not just 25 days history. The history is probably much longer. So what kind of infection are we talking about? So do you think, and then another thing is few glomeruli show segmental endocapillary hypercellularity, focal periglomerular fibrosis. So these are things which you, obviously one thing is clear, the striking thing is it's a proliferative glomerular pathology. So we're not talking about membranous or minimal change or FST. So we are looking at some kind of proliferative morphology. It could be, as you said, resolving infection related. Why would you want to really believe it's PSGN? We have no clue. 21-year-old. You can say post-infectious, para-infectious. These are the better terms rather than PSGN. Why would you want to limit yourself to? And I don't think you said you had shown a positive ASO titer, right?
Sir, yes, ASO titer has not been done, sir.
It's not been done. Okay. And when you say there's a non-necrotizing, obviously in a resolved or a treated or a healed tuberculosis, you will not see necrotizing. So,
sir, but there are no epithelioid histiocytes. There are no Langerhans giant cells. There are no.
Yeah, so that is, let's say it's another thing. You already said tuberculosis was treated. So she's a treated case of tuberculosis. So, so that could explain. So do you think tuberculosis can explain everything?
No, no, sir.
So obviously C3 again. So here, anyone has a different thought here? What is against C3 nephropathy? The predominant is IgG, right? And then of course you have C3 as well. I think it could be a resolving post-infectious glomerulonephritis. Less likely to be C3. Importantly, there are no crescents as well. Dr. Kailash?
Yes, sir. I agree, sir. Yes.
So, anyone, can we have, so how will you treat such a case? Soubeer, how will you treat such a case?
Sir, we would, sir, like to get you can get the urine. Sir, we got the urine culture and the blood culture done in this case.
Won't you ask for electron microscopy?
Yes, sir, I will definitely ask for electron microscopy. I've already asked for it, sir. Actually, the report came yesterday, so sir, they are getting it done wrong.
Yeah, so that's the first thing. You need more information.
Yes, sir.
All right. Okay. What would you want to see on electron microscopy?
Sir, electron microscopy, we can find subepithelial humps in this case, sir, due to streptococcal pyrogenic exotoxin B. Sir, but then again, if there are humps also present, then humps can be present in C3 glomerulonephritis also. Sir, that is why, sir, it is very difficult to, sir, differentiate between resolving PSGN and C3 glomerulonephritis.
Right, but then the ASO titer will help you. The persistence of hypocomplementemia is the most important thing. If you go back and get your patient C3 rechecked, I mean, if even at the end of 8 weeks the C3 is low, obviously you will think more of C3 nephropathy, right? Rather than okay. How will you treat this patient? If he would come to you, let's say 2 months ago, when the creatinine was just 1.2, the proteinuria was 2.5 grams. How would you have treated so that she wouldn't have landed up in this kind of situation, if of 30 to 40%?
Sir, I would have given, first of all, I would have given, sir, broad spectrum antibiotics, or if the culture is present for positive for some organism, I would have given according to the antibiotic sensitivity. Sir, yes, sir.
Which commonest thing? Which kind of staph do you expect?
This was Staph
Which,
aureus.
yes, so it's a common. It's a Staph aureus only, which is accounting for SAG. Yeah. Okay. Then subsequently, how will you treat?
Sir, if
Antibiotics?
yes, sir, sir, I would like to give antibiotics, sir, and if there is, sir, persistence of hypocomplementemia, and then I would, if there is persistence of renal dysfunction, or there is persistence of she does not have oliguria, or if she would have been oliguric, then I would have, sir, thought on the lines of C3 glomerulopathy. Then, sir, C3 glomerulopathy in 25% cases can have a mesangial proliferative pattern. In 18% cases, it can also have a crescentic pattern. Then, sir, according to C3 glomerulonephritis, sir, after getting her tested for paraproteinemia, which includes serum and urine immunofixation, serum and urine electrophoresis, serum immunofixation electrophoresis, and sir, serum free light chain assay. If that were to be normal, then I would have started her on mycophenolate mofetil. And sir, then, sir, if MMF she would not have responded to it, then sir, there are some therapies in C3 glomerulopathy going on with eculizumab. Sir, that is how would I have treated, sir.
Wait, what are the? When do you give steroids in acute glomerulonephritis?
Sir, in acute glomerulonephritis, sir, we can give steroids when there is crescents, sir, present, and sir, depending upon the diagnosis. When there are crescents.
Let's say a child comes to you with PSGN.
Yes, sir.
You diagnose as acute glomerulonephritis.
Yes, sir.
When would you want to give steroids and when not? You said crescent, that is correct.
Yes, sir.
Anything else?
Sir, if sir, the patient has sir, non-resolving symptoms, then I would like to give them sir, steroids, sir, in the form of, sir, persistent oliguria, persistent hypocomplementemia, renal dysfunction, persistent renal dysfunction not responding to treatment. So then I would have chosen to give her steroids.
All right.
Yes.
Okay. So supposing it is membranoproliferative. Now you don't have evidence that the basement membrane is not thickened, so there's no evidence of MPGN. So it's basically we are looking at some kind of partially resolved glomerulonephritis, right? Okay. All right. Anyone? We're short of time now, so आप इसको हटा सकते हैं. I think you can stop sharing your screen now.
I'll suggest, sir, ask him to get the ASLO titer and one HbSAg and CV also done. They have not done. He has not shown any reports of this.
I think that's the most important point. We cannot go away from the fact that the basic workup should be complete. I mean, there is no way you can escape not getting hepatitis B and hepatitis C checked. So I think it will be a blunder if you don't get it done. And of course, it's going to be essential even before you do a biopsy. That's very, very important. ASO, yes, we are all the time talking about infection related, and obviously we should have got ASO titer done. Repeat C3 after some time, repeat and look for the electron microscopy changes, and then we accordingly plan the final treatment. What do you think is going to be the likely course? Soubeer, are you there? Anyone? Mehak Singla, आप बताइए, what do you think is going to happen to your patient, to this patient?
So, good evening, sir. So, as the
Hello?
effect on higher side, I think we should don't go with the immunosuppression as the effect is already on higher
Yes, I agree.
and watch.
No, it's not the creatinine. You see, no, creatinine should not be the criteria. You would actually want to give and bring down the creatinine, but what holds you back is a significant IFTA, and what holds you back is a chronic inflammatory cells.
Changes.
So there are in fact on the IFTA, and then you have a dense chronic inflammatory inflammation. So these are the 2 points which may not really compel you to start steroids. So Dr. Shashank
I
Jain.
just want to ask something, sir. Sorry to interrupt. Sir, if IFTA would have not been that high, then should we go with only steroid or we should add some other immunosuppression as well?
I think we must first try steroids in case IFTA was not that much, and if the cells were acute in nature rather than chronic inflammatory cells, one would first want to give a good course of steroids depending upon the response to steroids. If it is a partial response, you may still want to add something on after reducing the dose of steroids, because you have to see the safety of the patient and just not be wanting to treat. So that's one. But there is no convincing data which tells you, in the absence of recents, should you go in favor of MMF or cyclophosphamide, right? It's only C3 nephropathy, and I don't think it's going to be C3 nephropathy as a strong possibility here. I would rather, because the predominant was IgG. C3 is just a co-dominant thing, right? So that's what holds me back. You see, you will be tempted to use high dose steroids so very often, but then you burn your fingers by using them when they're actually probably not going to help in any case. Dr. Shashank, any other thoughts? Dr. Shashank is there? Dr. Atul, can we hear your last minute comments as to how would you be wanting to treat your patient? It's just a hesitation, or I hope it's not कि सबने log in किया हुआ है.
Sir.
And I hope I don't find you people in Saket Mall.
सर ये इसने 2D को किया है कि नहीं किया पेशेंट का? हेलो.
हाँ सर, 2D को सर हुआ है सर.
अच्छा, there is nothing cardio.
Nothing, नहीं सर.
So that is a very interesting observation which Dr. Kailash has got. Very, very important. So many times, even in the absence of fever, infective endocarditis. So always keep that as a possibility. I agree, fever is not there, so it will be less likely. But then you see, unless you get it done, so Shashank wants a per rectal examination. Shashank, any particular reason? Dr. Shashank? Shashank ji, we are curious to hear your reasons of course, that there is, Hutchison said it should be done for everyone, but why in this particular patient? Shashank ji, we are still eager to hear from you. Rectal abscess, PHEN, okay?
Okay.
Without any symptoms? So obviously, you know how bad can rectal abscess be. How bad can rectal abscess be? I don't think it's going to be very often for you to miss rectal abscess in the same. So, okay. All right. So Mohit says antibiotics and steroids timing in this case we consider, and I think in case of staph, probably all that you need is antibiotics, which will probably reverse. But here you don't, in all probability, have staphylococcal associated because IgA is negative. So IgA negativity, and I think there are a few other clues which say that probably we're not dealing with staphylococcal associated, staph associated AGN. Right. Dr. Kamakshi, your parting comments?
Dr. Ghosh, blood culture was sterile.
Yes,
Hello?
sir. Yes, sir. It was sterile.
Okay.
Dr. Kamakshi, you wanted to say something? Okay, I think that was quite interesting. So we've done a good job. So that was the thing. Of course, I am sorry I couldn't attend the initial part, and I'm sure Dr. Kailash can comment whether he was happy, satisfied with your history taking and
Yeah,
your
actually,
initial
sir, this patient, history was very short history. Only history of 2 weeks is telling and sudden onset on all this thing, and all other things were negative. There is nothing positive history except high creatinine and history of hypertension, he told, and symptoms of nephrotic syndrome.
Yes. So 25 days history.
Yeah.
All right. Yeah. Okay. So now you know how often do we may be believing that history is short, but obviously you can understand these kind of biopsy changes haven't happened over 25 days. They've definitely taken much longer.
Yes.
So I am not saying that your history taking was not correct, but I think we always should attempt to dig deeper and try and figure out whether we have missed anything. I mean, a very subtle point, patient taking antibiotics or whatever, ATT, you should have given more importance to the fact that she had tuberculosis. So was that in any way responsible? Earlier on, we used to believe that tuberculosis may not have much to do with the kidneys. Not any longer. Tuberculosis can really wreak havoc as far as the kidney function is concerned.
Sir, I told in detail in the past history, sir.
So I agree. I'm sure you had done that.
4 years back, she was treated for it.
Yes,
Yeah.
sir. Yes, sir. Yes, sir.
Okay. So obviously you can't expect that, but अगर तभी कुछ कोई chronic inflammation हुई होगी, but then these changes जो आप देख रहे हैं, they are endocapillary proliferation है, बहुत पुराने भी नहीं हैं.
Sir, the pathologist was very confident that this is not tuberculosis. They basically
I
said,
totally agree. लगता ही
Yes,
नहीं है, you don't get endocapillary proliferation.
sir, they said that the granulomatous inflammation is mainly because of drugs, secondary drugs, sir, that can cause it.
वो तो बड़ा rare सा episode.
हाँ,
ठीक है. चलो. Any questions? Last minute questions from anyone?
Sir, Dr. Khullar, sir, I am asking. I am your student still. My question is, we are not getting any evidence of infection in this patient and rising creatinine. Can we give the trial of steroid in this patient at this scenario? At this
difficult to answer that question. You see, because we are always, as I said earlier, we are tempted to give, but it so very often backfires.
No, actually, her creatinine is jumping from 2.6 to 3.2 within 5-7 days. What is telling in history?
Yes.
You are right. I think
something active going on, and we are not getting any evidence of infection. I will suggest 2 things. One, you get the transesophageal echocardiography done. Still, you rule out the subacute bacterial endocarditis. TE, you get the TE done.
Yes, sir.
And you repeat, and nothing suggestive of infection.
I agree. You have a point because patient आपके सामने sick होती जा रही है. You are losing the kidney function, whatever is left of it. And I think at times you would tend to believe that maybe the biopsy was not the true representation of the overall biopsy. Maybe उस particular area में IFTA 30-40% है, while the adjacent area, if you've done a biopsy from an adjacent area, the IFTA may have been just about 10-15%. So I get your point, and I think that's you have to individualize. And at the end of the day, it's the patient in front of you. So once you have convincingly ruled out all possible infections, maybe I stand corrected. I may this thing, but you have to very carefully and in detailed manner discuss this with the patient and the family, the pros and cons of giving immunosuppressants, and only then go ahead. Because you can be questioned as to why did you use when the biopsy had shown significant chronicity. But yes, you're right. When the creatinine is jumping, you may at times be falling in that trap. But how often do we gain success? I think it's controversial. Okay.
Okay.
Good. Nice job, Soubeer, and keep it up. Very nice. And I think they were interesting, very interesting comments, and good. Keep it up. All of you are doing great job, as I always say. Very nice. Bye-bye, and have a
Thank you, sir.
Thank you, sir. Thank you. It's always
Very
academic
good.
feast to have
Very
you,
good.
sir.
Very good case, Dr. Ghosh, and very good night, Khullar sir.
Okay, good night, Kailash. Always a pleasure to have you alongside.
Happy Teachers Day coming. Teachers Day is coming.
Thanks, Kailash. Thanks.
Thank you.
Thank you, sir. Good night.
Thank you, sir.
Good night.